So I think that was a nice setup between Paul and Nick for this talk, which I'm going to deliver, which relates to chronic venous disease progression, and I have no relevant disclosures here. What we know is based on data from epidemiologic studies as well as so essentially cohort studies as well as some case control studies. Again, these are all associations. The cause and effect questions that Paul just raised are not answered by these types of data, but they give us some insight into what we're looking at. So from these epidemiologic studies, what I'm going to do today is talk a little bit about what the incidence of new chronic venous disorders are and what the incidence of progression of chronic venous disorders is from C2 to advanced CVI, as well as from CVI to worse CVI, with CVI defined as C3 through C6. What I'm not going to talk about are the progression of ultrasound findings. We don't have time to get into the progression of DVT to post-thrombotic syndrome, which is an important question perhaps for next year, and also the progression of pelvic venous disorders, which we really don't know much about as well. And Dr. Rosenblatt will follow up with what we need to learn. So what is the incidence of venous disease in patients who are previously normal? Well, we begin our understanding of this to some extent with the granddaddy of all the cohort studies, which is the Framingham Heart Study, a prospective study of over 3,800 patients that were reassessed every 2 years with 16-year follow-up at the time of the publication that's at the bottom. And what we found is that in this particular study, the annual incidence of new varicosities in patients who previously didn't have them is about 2.2%, with a higher rate in women. And that's where this number came from, and this concept of women having more varicose veins. In fact, the whole concept of risk factors, that term was coined by the Framingham investigators. And the risk factors on univariate analysis for the development of varicose veins in women were obesity, sedentary lifestyle, hypertension, and coronary disease. The same conglomerate of risk factors for cardiovascular disease in general, sort of resonating with what we've heard a little bit earlier. And for men, it was atherosclerotic disease and smoking. The probably strongest evidence we have epidemiologically for the incidence of varicose veins is in the Edinburgh vein study. Almost 1,600 patients, or people, not patients, again, seen every 2 years, and they reported on 880 who came at follow-up at 13.4 years. 555 of those 880 had no venous disease at all at the time of their entry into the study. And so looking at the incidence of venous disease in that population, 101 developed venous disease across the spectrum. So that's 1.4% per year over that 13-year period. Those who increased from just C0 to C2 represented 0.7% per year. So a very small fraction, but a continuously growing prevalence as a result of that. Their univariate analysis demonstrated associations with family history, prior DVT, and phlebitis. And also a clear difference in terms of the incidence by age, where people in these earlier years were less likely to develop new veins than people who were older. In terms of chronic venous insufficiency, more advanced disease, the rate of development was similar, 0.7% per year. The predominant amount of, or the predominant grouping or development was edema, C3 disease, and only a small number of patients went from C0 to C4, and a very, very small number from C0 to C5, 6 over that 13-year period. So the incidence of advanced disease, although as common as the incidence of varicose veins, it's primarily in the form of edema. The incidence was equal in men and women, and obesity was the factor that they found that associated with advancement. So what about progression of disease from patients who have it before and then have it worse later? So from the Bonn vein study, which is only an abstract really, although we see snippets of it being presented in English at meetings, 1,978 patients, and they saw 84.6% of those at 6.6 years, and they noticed the prevalence of varicose veins increased a small amount, as did the prevalence of chronic venous insufficiency. What they did point out is that the progression in their presentations is a similar number to what we were seeing before, but they had seen no C2 cases presenting progressing to the C5-6 level. And specifically, they noticed that progression was more likely in patients who had associated saphenous vein reflux than those who had non-saphenous related varicose veins. Going back to the Edinburgh study and looking again at that 880 patient cohort or people cohort that had no venous disease or had venous disease before, 334 of those patients were between C2 and C6. And this is a slide from their study showing of those patients, of the 880, they had been able to re-examine with ultrasound and physical exam at the 13-year follow-up. 334 of those started out with varicose veins, and ultimately 57% of those advanced. So I'm going to go through each of these subgroups quickly on a summary slide now. So any progression was identified in 4.3% of patients per year. Those who had C2 who progressed to advanced CVI, 2.5% per year. So we're starting to see some patterns. And again, none of those patients with C2 disease over that 13-year period progressed to ulcer disease. For patients who already had CVI, progressing to worse CVI, a similar number, 2.6%. Again, most of the patients who progressed to edema. And only a small number of patients with CVI ultimately that wasn't ulcer disease before progressed to ulcer disease later. The risk factors that they identified on a multivariate analysis were prior deep vein thrombosis, family history of varicose veins, superficial venous insufficiency, particularly small saphenous vein, which is interesting, and axial deep vein reflux. In addition, older patients and those of female gender. So there's some additional data from some smaller cohort and case studies, and I'd be remiss not to comment on two papers by Nikos Labropoulos. One was a cohort study of patients who were waiting treatment. This is a single-arm study just following patients over a mean of 19 months while they awaited treatment. About half the patients were C2 or lower and half had CVI to start with. He noticed over that time period progressive symptoms in 14%, a progression of the C class in 11%. Specifically, again, most of the patients are advancing up to from C2 to C3, but even those who had CVI before, there was some progression to ulceration. And the incidence of progression of reflux was identified in 23% of those patients, but 95% of the time, the ultrasound at 6 months was unchanged, and that's sort of that's where we get this ultrasound good for 6 months kind of concept from. It's from this observation in the study. And that the progression was both antegrade and retrograde, reaffirming some of the comments made by some of the other speakers. And there was also a case control study that he took a group of patients who had first DVT, 41 patients and 46 limbs, and compared them with matched patients who had primary CVD and then had no prior venous disease. He followed those patients over 5 years with duplex ultrasound and physical exam, and he saw them 3 times over that interval. And what he saw is that new skin changes were much, much more common in patients who had had a deep vein thrombosis than who had had primary reflux or were normal at the time. And so substantial increase in skin changes in patients who are post-thrombotic, so to speak. Skin changes were most common in patients who had persistent obstruction and reflux on the follow-up ultrasound, and also most common in patients who presented initially with multi-segment DVT as opposed to a single segment of DVT. So this is some interesting information too. From one of the investigators in the Edinburgh trial, a retrospective case control study of 120 patients who had ulcer to some matched patients who didn't have ulcer but did have C2 disease. And what we saw in their multivariate analysis were some observations that included pre-existing skin injury of some sort was associated with future development of venous leg ulcer, deep vein reflux, and higher BMI also associated, and what were considered protective, and this goes along with what we had discussed yesterday, were good pump muscle function metrics. So To conclude with all these numbers that I just had in terms of picking and choosing the best numbers, the incidence of new varicose veins in previously normal patients is about 0.7% per year. The incidence of CVI in previously normal patients that excludes edema, so we're going to talk specifically about C4 disease, is a fairly low number, and the incidence of ulceration in that population is extremely low per year, but it happens. Progression from varicose veins to CVI, about 2.5% per year, but 3/4 of those are to edema, 1/4 of those are to skin injury, and then at least in the trials of the duration that we're looking at, no significant development of ulceration. Saphenous vein reflux patients may be more prone to progression, and then when we look at those who have CVI who progress to ulceration, the estimate is a number somewhere in the range of this based on drawing best numbers. Risk factors: prior skin changes, prior multi-segment DVT, deep vein reflux, BMI, and lipodermatosclerosis. The association between it and the development of venous ulcerations is probably the strongest evidence that exists for that. So with that, I'd like to conclude my study, and again, thank Nikos and Tony for this relationship that we have between the American Vein and Lymphatic Society and the Venous Symposium and the opportunity to speak here. And I'm going to bring up Mel to speak in comment to my talk.